you'll receive a talk from Frank McKenna until approximately 4, and then I'll be talking to you about causation. And then we've got 2 case studies to present to you. One is a road traffic accident, and the second is clinical negligence incident. And then hopefully at 4:45, if we're running on time, which I appreciate is always easier said than done, we'll draw some conclusions as we see appropriate and take any questions. But of course, if you have questions, please do just ask them as you go along. Fibromyalgia is a very interesting area and illness which crops up into medical legal work and personal injury litigation. I think, certainly from my perspective, it's a very difficult area. I think part of the difficulty is that lawyers don't necessarily have a command of the detail as they do in other areas. A fractured arm is very easy to understand as opposed to something as complex as fibromyalgia. And also what seems to be a challenging issue I've experienced, I'll be interested if other individuals have experienced this, is that, and hopefully Frank will talk to us about this, is that you often see references to chronic pain and fibromyalgia being used almost interchangeably, especially in GP records. And that can really blur the picture here. Anecdotally, I think it's an area that's finding its way more into litigation, but that's only my experience. I'd be very interested if others seem to be coming across fibromyalgia cases more and more, and perhaps Frank may be able to shed some light on, why that may be. Is it a progressive area of understanding compared to other fields of medicine? So, on that note, I'd like to welcome up Frank to talk to you. I should say this is not my picture, this is Frank's picture, and I understand he's going to explain it to us, so thank you very much.
You're very kind for inviting me. Hello. Please interrupt at any time if you wish to do so. The photograph is for a self-portrait that Frida Kahlo did. She had a serious car accident when she's in her teens, and then for a lot of, she's a Mexican post-impressionist painter, and for a large part of her life, then painted about pain. And I think this is just a fairly good graphic example of how patients with fibromyalgia might feel. But anyway, that's why we've got Frida Kahlo there. And what I wanted to do initially was just to try and clarify a little bit about terminology, because you'll see these terms often used randomly or implying they're the same thing. ME, myalgic encephalomyelitis, is not a disease. It's a terminology, it's not even a medical terminology, but has been used as loosely to reflect chronic fatigue syndrome. And fibromyalgia is a separate condition. So, and very often you will see that there are now these ME/CFS clinics, and many of them actually have fibromyalgia patients in them, and the nurses who run them don't easily recognise that. This is chronic fatigue syndrome. The patients sleep for England. They're asleep all the time. They sleep for 12 hours. They wake up, they want to go back to sleep again. It's a very, very different pattern of somnolence to what you see in fibromyalgia. So the patients with chronic fatigue syndrome do, as part of their criteria, and for those of you who've done any of this will know about Fukuda criteria, almost identical to the current NICE criteria. And patients have to have chronic fatigue plus a few other things. And they may get muscle pain, multi-joint pain. But the point of these patients is that their predominant symptom is fatigue with a bit of aches and pains. And it's a different condition to fibromyalgia, whose predominant symptom is pain with fatigue. And sometimes it can be very difficult to differentiate one patient from another without asking that question, what's your main problem? My main problem is pain. That is what is fibromyalgia. And this reflects 10 points, which I'll mention in a minute, which is a sort of pseudoscience that crept in many years ago. But the patients tell you they don't sleep. They do sleep, but their sleep is very fragmented, and I'll show you some information in a few minutes about that. They always have cognitive dysfunction, and they're always miserable. And the symptoms they have, sorry, yeah, that doesn't, can we go back? Which should we go back on? Yeah. Sorry, just before we come on to the symptoms, it's a condition that's been around for a very long time and called different things. So into the 19th century and until probably the 60s or 70s, it was called neurasthenia, and there've been a large number of studies done over time. So I just quoted this Mayo Clinic one. They did muscle biopsies in patients in the 1940s. So it isn't a new condition, but it was defined in the 1970s by some Canadian clinicians, Hugh Smythe and Harvey Mordowski, who not only defined it as being a triad of, this isn't shown very well, but anyway, I'll read it out. At the bottom here, triad, restorative, chronic, widespread pain, fatigue and non-restorative sleep. So that is what the condition is. You have to have all of those things. You've got to have non-restorative sleep, which usually the patients complain severely about, widespread pain, not local pain, and fatigue. And the fatigue is actually caused by the sleep disturbance. How common is it? This is a European study that was published 10, 12 years ago, and the line at the bottom is men, the dotted line at the top is women. In clinical practice, the ratio is of females to males is very different to that. It's probably 8 to 1 rather than that. It looks about 2 to 1. But in these studies, which were done by questionnaires, that was the prevalence. It's about 3 or 4% of women in the population, middle-aged women, will have it. And these,
sorry, Frank, just on that. Is there any evidence or research that suggests why women suffer in greater numbers?
It relates to psychological ill health, which is more common in women than in men. Okay. And the ratio of that, I think, relates to that. And I'll discuss that in the next slide or two. Yeah.
To take notes as well, or will these be available?
They'll be available. Sorry. Feel free to take notes.
I could distribute the slides as well afterwards on a PDF or something. So this slide just highlights what I've said about sleep disorders, majority are female, and then a whole host of other symptoms which are different in different patients. But very often, a lot of patients will complain of all of these things. Headache is part of the criteria. A lot of patients will complain of paresthesia or other neurological symptoms, IBS is common, and so on. So the diagnosis is that we currently use is this one, but it's been debated about how you make the diagnosis for many years. But this researcher in the States, Fred Wolf, has spent his life looking at patients with, or how to assess fibromyalgia and discussing the manifestations and what it is. And this is the current criteria. So widespread pain index at more than 7 sites. So that's different parts of the spine, shoulders, hips, arms, upper and lower arm, and so on. So it has to be also in at least 4 out of 5 regions. So it's widespread, it's not localized pain. And there are other symptoms which are related to it. So I've put here a score, symptom severity score, somatic symptoms. So fatigue, waking and refreshed, cognitive dysfunction, scored on 1 to 3 scale, plus whether the patient's in the previous week had a headache, abdominal cramp, or depression. And that's how we make the diagnosis. It's done by a questionnaire, so you don't need to examine the patient. The thing about all patients with fibromyalgia is they have psychological vulnerability, and in my opinion, if they don't have that, or if any of us don't have any significant psychological vulnerability, we cannot develop fibromyalgia. It's a psychologically mediated illness that links with our pain pathway, and I'll show you in a minute or two how that impacts. And there are various ways of trying to define psychological vulnerability, and there have been a very, very large number of published studies. This is one of them, which indicates what sort of psychological and other history and history of trauma patients would have had in the past. So comparing the pale green with the control, it is remarkable in this control group to see how common child sex abuse was, but whether that was how they developed their control or gained their controls, I'm not sure. But the point about this is that all abuse, whether sexual, physical, drug abuse, is more common in patients with fibromyalgia. And this is a meta-analysis of 13,000 subjects, which just underpins that. So for those of you not familiar with odds ratios, these numbers tell you how many times more likely it is that you will have one condition compared with the population. So an odds ratio of 3 means you're 3 times more likely to have something than compared with average. So the history of sexual abuse in childhood or adulthood, 2.5 to 3 times more likely to have that history in fibromyalgia patients, and similarly with physical abuse. What happens then when someone develops the condition is that their pain mechanisms become abnormal, and this is a graph showing what is the normal pain response in all of us. So if you increase the amount of pain, that's the severity of pain. The more you increase it, the more you feel pain. Now, one of the things that you have in fibromyalgia is that all shifted backwards. so that a stimulus which is not painful, like pressing on someone's muscles, becomes painful. That's hyperalgesia, or that the term for that, as I'm sure you know, is allodynia, where you have a non-painful stimulus is painful. And you can demonstrate that, and this has been demonstrated in a number of studies. So this is one study, quite an old one, from over 20 years ago, 25 years ago, and if you increase the pressure, so this is a thumb. I don't know if you've ever followed the ways that pain specialists inflict pain. They have a sadistic quality about them, I think. They use a thumb screw, this is a thumb screw, or a laser to burn you. So if I was you and you're invited to participate as a control, I would decline, because you will suffer pain. But anyway, this is pressure intense. This is the thumb screw, and you gradually increase the pressure, and you can appreciate that we will have a certain amount of pressure, which we don't think it's painful, and then suddenly it becomes painful. In fibromyalgia, that isn't the case. Even light amounts of pressure become painful. So how does that relate to tender point examination? Well, this is a study that we did 20 years ago. As you would imagine, having just described what happens and what is known about pain and tenderness in fibromyalgia, then tender points will be more tender. Now, I mentioned Hugh Smythe, who was essentially the father of fibromyalgia. When I was a trainee, a senior registrar, he visited our unit, and I happened to be sitting at the front, and he was teaching us about tender points, and he came up to me and said, "Well, I'll show you, I won't do it." And he rolled his finger around here, and I had pain in my arm for a day afterwards. The point is, these points that you may read about, these hyperalgesic points, are tender in everybody. They are places which, because they're more tender, mean that you would have to have only a certain amount of pressure to then be painful. So these are our controls. These were people without any pain. I'm one of these, and we had a researcher going around, and for all the different tender points, using a pressure gauge to apply pressure, and then recording how much pressure you needed to press before we said it was painful. Now, in the old publications from 1990, it talks about pressure, how much pressure you need to apply. It was 4 kilograms. Now, this is done so differently by different people. But on average, you need probably a little bit more than 4 kilograms pressure before we feel it's painful. In fibromyalgia patients, you hardly need any pressure. As you would imagine from the data I've just shown, they have a very low pain threshold. And so counting how many points are tender or not is nonsense, to be honest. And in fact hasn't been part of the criteria of fibromyalgia since 1990. Now, what is going on, and I hope you'll forgive me for showing a little bit more scientific evidence, which I think is quite interesting. Pain is the most important sense that animals have, and it's a whole brain phenomenon because of that. And the way that our brains work with nearly everything is through pathways, and you form the circuit in the pathway, and we then are aware of our surroundings and different ways. So the pain is no different. The circuit joins up and we feel pain. And there are two major systems. There's a lateral system which tells us where the pain is, and then that circuit will end up in one part of the brain which we can identify as the arm, leg or whatever. But there's also a medial being in the inside of the brain which relates to the unpleasantness of pain. And these are fired by the same way, coming through the spinal cord from peripheral nerves, and then they're triggered. This just, and I've thrown this up just to show that there are different parts of the brain, so cingulate cortex, thalamus, insulin, number of others which are part of this pathway. And when we feel pain, these all join up. Now, what is interesting, one of the things that's interesting in patients with fibromyalgia is that the way that these pathways work is different to normal. So this is a study that was done in Manchester by a colleague of mine, in fact, where he put people in a functional MRI scanner and used the thumb screw technique while they're in the scanner, and then asked them to focus on how unpleasant the pain was. And then this is the part of the brain that's part of that medial pathway. And he then asked them to, instead of that, focus on where the pain was. And here's the lateral pathway showing the part of the brain. But when those individuals, the healthy volunteers, did that, as you can see around the red circle, that's the unpleasantness bit, and that was blocked out. And also the area that where the pain, you would feel localizing pain when they thought about it being unpleasant, wasn't shown. And patients with fibromyalgia can't do that. They can't separate out when they've been put in the scanner with the same technique. They can't separate those out. Why is that? This, to me, is the most interesting piece of scientific data I've seen, not just in relation to fibromyalgia, but in other areas as well, because it is so extraordinary. And I'm going to spend just a minute trying to explain what it is. So you recognise the insula I mentioned, that's part of the pain pathway. And what these researchers did, and it's now almost 15 years ago this study was undertaken, they only had 18 patients. They put them in a scanner, and they asked them, when they went in the scanner, how much pain they had, and they looked at different parts of the brain that were that lit up. So they, which is what this is. So the amount of pain and how much of this part of the insula lit up. But what they also did was looked at other networks, and one of these is this thing called a default mode network, which is this axis here. Default mode network is one of these other pathways in the brain that hopefully none of you are using now. It's one when you're resting and not thinking. And so it's a rest state pathway of the brain. So it's a consciousness pathway, if you like. And what this showed is a correlation between that pathway and the severity of pain linked to the pain pathway with those figures. Now, again, I don't want to dwell on statistics too much, but an R value is related to how much something correlates. So an R value of 1 is an absolute thing. So in daylight, the sun is in the sky, at night time it isn't. That's an R value of 1. This is 0.7. So the absolute way of saying something is absolutely linked is an R squared value. So that's 0.5. Essentially what that means is half, literally half, of the pain of these 18 people can be fully explained by that one connection between the pain pathway and the default mode network. In only 18 people. It is remarkable, that, I think, piece of evidence. It really does show where the pain arises from. It's a short circuit. It's a short circuit between the pain pathway and other pathways. And it's not just this one, not just the DMM, the default mode network. It's others as well. So that is a little bit of a window into some of the functional MRI studies, and there's been a lot more done in the last decade. They are phenomenally difficult. We tried to do some in Manchester, and it's, the calculations are, beyond most people, let's put it that way. Okay, so I mentioned that fibromyalgia occurs in those with psychological vulnerability. There's a significant reduction in pain threshold. The predominant with the medial pathway, the pain pathway that is unpleasantness, and they have abnormal neural connections. So what is the trigger then? Because there are a lot more people who are vulnerable who don't develop it. And my own view is that it is the abnormality of sleep on top of the psychological abnormalities and the history and vulnerability that then leads to the problem of these short circuits developing, these abnormal neural connections. Now, what is the evidence for that? Well, we know that for those who are insomniacs, there'll be one or two in here, I imagine. People with insomnia have lowered pain threshold. So these are studies which show that. So using the thumb screw or the laser in people who have insomnia, you can see that the pain threshold is lower. And also people with insomnia have complain of more pain on a day-to-day basis. You can also induce essentially short-lived fibromyalgia by just stopping people from sleeping properly. There are 3 studies which are identical to this now, where they've taken male volunteers, medical students in other words, and then put them in a sleep lab and prevented them from having certain types of sleep. And in this study, what they showed was that if you relate the amount of, so they prevent the amount of deep sleep, shortwave sleep, that the amount of pain that these subjects then had, aches and pains after 5 days, was correlated with the amount of deep sleep they had. And we've all had this, you know, if from long distance air travel and jet lag, people feel unwell, they feel they've got aches and pains, and they have other symptoms. And that's sort of similar to what patients with fibromyalgia have all the time, but their symptoms are more severe. Other pieces of evidence about sleep. This is a Scandinavian study. They survey the population about health matters every decade. And so this is 10-year follow-up of 12,000 women. And what they did was they looked at from one questionnaire to another one 10 years later, and looked to see of those who had poor sleep and were not complaining of pain, how many of those then complained of pain, frequent pain, 10 years later. And for those who often had poor sleep, or who had poor sleep, they then developed more aches and pains. So what is it about sleep in fibromyalgia? What is the abnormality that might lead to this? Well, this is an EEG, sleep EEG. This is one of our controls that we did quite a few years ago. And what happens is you start here, that's when you're awake. Then there's stage 1 sleep, which is light dozing, medium sleep and deep sleep. This is what's called often called slow wave sleep. And that cycle from going to sleep to here lasts about 90 minutes. And then we have, well, to the end of here, last 90 minutes, we end up with rapid eye movement sleep, and the whole thing starts again. And we have these cycles. The whole cycle takes 90 minutes, which is the reason why we wake up usually after an hour and a half, 3 hours, 4.5 hours, 6 hours, or whatever. And as the evening goes on, we get more rapid eye movement sleep and less slow wave sleep. So you can see here, this is now more fragmented. And this is what's typical in fibromyalgia. So they do fall asleep, but they don't stay in slow wave sleep, and it's fragmented and the pattern is all over the place. And we see this in all of our patients with fibromyalgia. This is a typical, and this is one of our patients who studied. And so you had this is, as you can see, the stage 1 where you're sort of slightly dozing. There's a lot of that, sometimes being awake throughout the night, and so on.
Dr. Frank, just in relation to that, would that help explain the age of onset of fibromyalgia? Being very scientifically loose, people always say, oh, well, teenagers, children, they sleep very deeply for a long time, but as you progress, as you get older, people start saying, well, my sleep's not as good as it used to be.
It's an interesting question. I don't know. I mean, there are patients of children who have what appears to be fibromyalgia. I suspect it's a bit different. I wonder if it's just accumulation of life traumas. What I didn't say is the average age is in the 40s, and sometimes people will develop it in later life, but usually it's middle-aged disease.
Yeah. Okay. Sorry.
I'm just really interested. So has that sleep cycle been compared with a group, say, who have depression?
Yes. So there isn't anything very and we've done that. So our study looked at patients with fibromyalgia and those who were being woken because they were waiting for a hip replacement, and they also have a lot of fragmented sleep. Patients with depression don't have that pattern, but there isn't anything distinctive about it. One of the reasons why we did this study was to see if we could identify a pattern where you, as a test, you can't. All it shows is their sleep is very poor, and for anyone else who sleeps poorly, then they all have that sort of pattern.
I just wondered how you separate that as being contributed to fibromyalgia, when actually that sleep pattern could be there in other.
So the question is whether it's chicken or egg. I think you're saying, and that is debatable. So it is possible that that they have that abnormal sleep pattern before they develop their fibromyalgia. I think that is possible. My anecdotal feel is that isn't the case, and when you look at what triggers there are, which we'll come on to in a minute, for fibromyalgia, then all of the triggers have as a common theme sleep disturbance. We'll come back to that. So in addition to that abnormality of sleep, what we found in the fibromyalgia patients was that they complained of a lot of sleep. These are the osteoarthritis ones. But what that correlated to was their psychological ill health. So it's the combination of those two things. And I think you need the combination of those to develop these abnormal circuits, if you like. And this is really flying a kite. If you thought it was flying a kite before about sleep being the trigger, this is even more so. This is data to show that during slow wave sleep, these bits of the brain only become inactive, in other words, rest and restore, and they happen to be part of the pain pathway. So you could make an argument that actually, because of the reduction in slow wave sleep, this part of the pain pathway doesn't recover properly. So how do you manage the disease? Well, it's a three-cornered approach, as you can imagine. You try and improve psychological health, but that tends to be very difficult because it's about life experiences from birth, but CBT and drug therapy and so on. You can try and improve sleep, and that is one of the areas that I think is possible to improve. And then exercises, physical exercises and so on, are part of the management. And just a couple of slides on the effect of drugs. So you will have seen patients who are prescribed amitriptyline, and this is compared with placebo. If you look at the benefit at 6 months here, say, compared with placebo, well, there is a benefit, and this is at 75 milligrams a day or in the night, but it doesn't cure the patients. And if you look more carefully at some of the data, this is trazodone, similar drug, the benefit is relatively modest. So these, the improvement, so this is before and this is after treatment. As you can see, pain, fatigue and so on, it improves statistically, but not very much from a clinical point of view. Pregabalin, gabapentin, the same. So as you can see, just looking, eyeballing these graphs, the benefit from here to here is pretty modest in whichever areas that you look at. But this drug is different, and this drug is one of the reasons why which reinforced my opinion about sleep being important. This is a drug that is developed and used in narcolepsy, and what it does is increase the amount of slow wave sleep. Now, maybe not by a massive amount, but this is in patients with fibromyalgia. But the clinical benefit of doing this is much more marked. These graphs are similar to those in with pregabalin and gabapentin. And I was giving this, or talk similar to this, at one of the American meetings some years ago, and this chap, Mike Speed, came up to me afterwards. These studies were only done in the States, and he said it was unbelievable how some patients had had this disease for 10 years and were essentially fully better, or as near as gamete, with the treatment. So it, unfortunately, and the manufacturers then tried to license it, and it's really good at inducing sleep. that it's so good that it's being used as a date rape drug, and it's the most highly controlled drug now in medicine, more controlled than opiates, morphine and so on, and they wouldn't give it a license because of that. Otherwise, that would be, I think, widely used. And the problem is any other drug that does the same thing and improving sleep that much would potentially have the same problem if it's used in, by criminals. Last slide in relation to these data, that's the prognosis. It gradually improves over time. It's not a progressive condition in the majority of people. This is an old study, 2011, but it's a large study, as you can see. It's 1,500 patients followed up for up to 11 years, but there was an average of about 7 or 8 years. And over time, patients tend to stay more or less the same, but fluctuate. Some get a bit better, and others tend to stay the same. Now, that's a bit of background. So, of course, one of the issues is about personal injury and whether this condition can be triggered by personal injury, like a car crash. Well, what is the evidence? It's not great, other than anecdotally. So this is a very old study. This was done 20 odd years ago, and he had 136 patients with fibromyalgia and asked them if they could describe any trauma that they'd had in the previous 6 months. So it's retrospective, and of course it can be criticised by false memory, etc. But these were the data. So, and they said, well, statistically, there were more patients who developed trauma in the 6 months rather than the control group. And the control group was a random group of patients in other outpatients. So I give a similar talk to this to patients with fibromyalgia, and I did so for many years, and always asked a show of hands how many thought their fibromyalgia had been triggered by something, and it was always a third of the room. And that's largely what the data, the retrospective data, has shown, that largely a third of patients can recall something that they think triggered their fibromyalgia. Now, what about car accidents? Well, this is the only data that has suggested that there might be something different about road traffic accidents triggering fibromyalgia rather than another accident. If you accept that fibromyalgia can be triggered by something, my own view is that a car accident is a big car accident is quite a good model because it's physical and psychological trauma. And I think that therefore there is an argument to suggest that car accidents could do that, depending on certain factors, depending on vulnerability, etc. And for what it's worth, what Wyn Jones showed with this, and I mentioned about odds ratios, so what he found adjusted for age and sex was that they were almost twice as likely to develop fibromyalgia following a car accident. If you adjusted for psychological distress, then maybe an extra 50% more risk. After whiplash, I think that this data is fraught with problems. Many people have quoted the Baskila study, this is done in Israel, where 20% of patients, he said, after whiplash injury developed fibromyalgia. And what the authors were describing were the physical symptoms and signs of whiplash, and they looked at them after 12 months. Otherwise, all of the hospitals in the world would be full of patients with fibromyalgia. There are 700,000 car accidents per annum. So if 20% of them develop fibromyalgia, we wouldn't be doing anything else. There is a data. And this is what Fred Wolf said about that data. And this, I don't know if many of you have come across this paper. This is a rant. This by him, essentially. And clearly he was very annoyed in the litigation world in the States by the concept that fibromyalgia could be triggered by physical trauma. I'll read out what it says. The only data appears unequivocally support the notion are case reports, case series and studies that rely on recall. So very low quality data rather than scientific evidence. So he isn't saying that it doesn't trigger it, it's that the data to support it is very weak, and I agree with that. And he says in his paper that there are 5 studies that contribute to that evidence. It concludes by saying the evidence is weak or null. Having said that, and I know some solicitors have found this quite helpful, that in terms of a trigger, the Royal College of Physicians document a couple of years ago said there's good evidence that experience of stressful life course for life events, such as major physical or psychological trauma, increases the risk of developing fibromyalgia. I think if a critical look at this paper would suggest that the good evidence is maybe an exaggeration. And that's what I had to say. I like this cartoon. There are defendants with lots of money in the room now. But thank you.
Okay, well, thank you very much, Frank. Does anyone have any questions at this stage for Frank? One thing that I wanted to ask you, because I think it will be useful for when I talk, is what is the evidence that suggests about a fluctuating state of fibromyalgia?
Yeah. So all patients have a fluctuating symptoms.
But
sorry.
Is there evidence, or in your opinion, that the more an individual is exposed to lack of sleep, as an example,
Yeah.
the worse the symptoms of fibromyalgia can become?
Yes. So almost all patients will say that if they have a particularly bad night's sleep, their symptoms are worse the following day. And that can be related to a stressful day at work, or an argument with a spouse, or whatever, and they will inevitably say, I mean, I think that and there's good evidence that the fluctuating course relates to that and to other stressors, and all of those other stressors the patients then say impacts upon their sleep and impacts upon their symptoms.
And in your opinion as a rheumatologist, looking and having looked at this for, however many years, do you accept that a patient will go from not having fibromyalgia, and then at a defined period of time they have fibromyalgia.
Yeah, there is an onset of the condition, and I think it can be explained. I think we understand it more with what happens with functional MRI and the often, if you're looking through paper records, it can be quite difficult to tease out. But it's generally the point when the patients develop widespread pain. And up until that point, they may have complained of a variety of symptoms, but the development of widespread pain, in my experience, usually develops over a relatively short time period. So that, and I think that is then can be seen that the condition is established. The difficulty, of course, in relation to litigation is that those symptoms might happen in the course of having a whiplash, where the symptoms of whiplash initially might mimic that. And we see patients who have symptoms of whiplash, but then rather than getting better, as most do over time, they develop more symptoms. So I think that the majority of patients I see will be able to describe an onset over a period of weeks to maybe months, but not longer than that. And once it develops, it persists. I must say that over time I've treated patients who have got largely fully better, and I've only been able to do that at the very early onset of the condition. And I think that's before these neural networks become hardwired, because after 2 or 3 years, then these abnormal neural connections, we get them, I mean, it's how these things develop in the brain, it's how the brain develops, how we ride a bike. We've got a fixed neural network for that, and you don't forget it. And unfortunately, with these abnormal neural networks with pain, after a period of time, it's very difficult to get rid of.
Can I ask a question?
Yeah.
Is it always trauma that will then lead to fibromyalgia?
No. No, I think the majority of patients, the majority don't have a trigger. So probably 2/3 of patients, it develops without an obvious trigger or without one they can define. You'll not be surprised to know that, to hear me say that I think that will be associated with something that's causing their sleep to be worse, but that might be the straw that breaks the camel's back, if you like. But 2/3 of patients do not have a trigger, and those that do have a trigger, very often it's psychological rather than physical trauma. And I think that psychological trauma is probably a better trigger. But in relation to car accidents, you get both. How minor degrees of trauma causing pain then may trigger it is a more complex argument, and in patients who say that that's the case, I look to see what's happened to their sleep.
So do some people have a predisposition to it? Do you think?
They all have a predisposition.
Because of the psychological element.
And it's major psychological vulnerability. Major psychological vulnerability. So I imagine everyone in this room has met patients with fibromyalgia, and they are very they're people who are very vulnerable in their own personality, and they're all the same. What is quite remarkable, and we've had this, at different meetings, that the symptoms they describe and how they come across they're a mirror image of each other. They're all the same. It's quite remarkable, really.
So all the symptoms are self-reported symptoms?
Yes, they are.
There's no diagnostic test?
There's no, it's very good for malingerers.
How do you, because in my experience as a case manager, in 20 years, when I go into an immediate need assessment, I can generally make a call then as to whether they will go on to develop fibromyalgia.
Oh, right.
Just by the sort of personality type
Yeah,
they
yeah.
are. And so how would you separate, if they're all self-report symptoms, how would you separate somebody who is just malingering for financial gain as opposed to somebody who has real fibromyalgia?
Well, it's down to clinical judgment, and you get a feel when someone appears as though they're not responding in the way I would expect. I ran fibromyalgia clinics for a decade, and mainly to feed into our research. In fact, predominantly I had a research nurse who did them. If you see a dozen patients back to back, you need to have a large glass of whiskey at the end because it's challenging. So it's down to personal judgment, really. I mean, that applies with most clinical medicine. It certainly applies with patients with fibromyalgia. And I've seen a number of patients where I thought, oh, there's alarm bells ring, and then maybe a few years later I find out they're being done for fraud, and I look back and see I was a bit lukewarm about what I'd written, and I was relieved about that. But you're right. Can I give one anecdote?
And then we'll move on.
Just kind of staying on. So there's a colleague of mine who saw a patient who was really disabled, and they went through litigation, got a large compensation, weren't able to walk, and he saw them strolling through an airport, and he said, "What's happened? Why are you better?" And he said, with the money I got, I went to Lord's." Well,
okay. All right. On that,
yes.
Thank you very much, Frank. We'll certainly take some more questions at the end. We're a little bit behind schedule. That's okay, because my talk on causation is hopefully quite narrow. Now, this is as you all know, a remarkably difficult area. Material contribution, and I don't intend to go through it exhaustively. Everyone will be aware of the principal cases, but I just wanted to touch upon a couple of issues as it relates to fibromyalgia, and as you can see there, whether or not it's a binary question, you either have fibromyalgia or you don't have fibromyalgia, but from a lawyer's perspective, the most interesting point is going to be, well, when did the fibromyalgia onset? Why did the fibromyalgia onset? And whether or not the alleged negligence played any role in the onset. So I've just put the decision of Mr. Justice Ritchie from last year up, which was a cerebral palsy decision, and obviously hypoxic ischemia. It's a case that you should all be familiar with. And I've taken from that case, as Mr. Justice Ritchie said, the 5 areas in causation where scientific uncertainty, gaps in the evidence, and impossibility of proof have a role to play. Now, multiple causative factors, one negligent and the other non-negligent, could make a very good argument it could come in any of them. But as it seems to me, and feel free to disagree with me, it's most likely going to fall within points 1 and 4. And that leads me then on to the question which, as lawyers, this is what we want to know. absent the negligence, would the claimant have developed fibromyalgia in any event? Now, everything about what Frank's been saying and the pathophysiology of the condition is very interesting from a medical perspective, but from a legal perspective, going to know the claimant is alleging that a car accident, a delayed diagnosis, unnecessary surgery, if that triggers it, and absent the trigger, would the claimant have developed it in any event? So it's obviously very much a causation question. Now, I tried for an inordinate amount of time to create this diagram. It's not quite what I wanted it to look like, but it's the best that I can do. But as you've heard from the medical evidence, you're going to be presented with a person that has underlying risk factors for fibromyalgia. Could be pain, could be insomnia, and certainly psychological vulnerability. Then we have the negligent, delayed diagnosis, car accident, and then there's the result of fibromyalgia afterwards. So when assessing causation, I think it's always going to be difficult to win on a but-for conventional approach. So from a claimant perspective, you're always going to be gravitating towards material contribution. Now, you should all be familiar again with the recent Court of Appeal decision in Holmes. Now, that was an industrial disease case as it related to the onset of Parkinson's. And I've included a quote there from Lord Justice Stuart Smith, which is where he sort of tried to really grasp the issue and say material contribution applies to indivisible injuries, which is welcome certainty for all sides of the legal profession. There's obviously lots of issues as it relates to his interpretation of that. But what I found very interesting about the decision in Holmes is, as I've already said, it's an industrial disease case, not a clinical negligence case. And it's whether or not there's a different approach that is subconsciously being applied to industrial disease litigation as opposed to clinical negligence, because industrial disease, it's almost always exposure to something. Asbestos is the classic, and it's often easier to draw a dividing line between exposure to X as opposed to an cumulative deterioration, Bailey and MOD being classic, in clinical negligence cases. So one of the things, certainly, now that the Court of Appeal has said it applies to indivisible injuries, let's look at what constitutes an indivisible injury. And this is I think it's going to have to go back into the Court of Appeal soon, because there is undoubtedly different dicta knocking around. So Jeremy Stuart Smith in Holmes said, it is a characteristic of divisible diseases that, once initiated, their severity will be influenced by the amount of agent that has caused the disease. By contrast, once an indivisible disease is contracted, its severity will not be influenced by the total amount of the agent that caused it. Stopping there and focusing on his use of agent, that's quite interesting. And you look at that and you possibly think, well, I really don't know then if fibromyalgia is or is not indivisible. But the use of agent in his analysis is particularly important. And again, it was an industrial disease case, so it's easy to speak of exposure to a tortious element, agent, or otherwise. But contrast what the Court of Appeal and Lord Justice Stuart Smith said in Holmes to what Mr. Justice Ritchie said in CNZ, where he said, in law, I consider that that the cases I have reviewed above show that if there is a scientific gap making proof of causation of functional outcome, therefore also quantification, impossible in contradistinction to nearly difficult, then the claimant will recover 100% of the damage she has suffered. And he goes on to say, obviously, so long as the claimant can prove that the breach made a material contribution to the reduced functional outcome, which was more than de minimis. So you can immediately see that there's a subtle but very important distinction about what the courts are saying there. So let's look at the decision in Williams, which was a Privy Council case and followed the Court of Appeal decision in Bailey, and it was a sepsis case. And Lord Toulson said in that case, in the present case, the judge found that the injury to the heart and lungs was caused by a single known agent, sepsis, from the ruptured appendix. The sepsis developed incrementally over a period of approximately 6 hours. So that's starting to sound a bit more like fibromyalgia again, isn't it? The sepsis was not divided into separate components causing separate damage to the heart or lungs. It's the development and the effect on the heart and lungs, which was a single continuous process. And then, of course, the Privy Council upheld the application of Bailey as a material contribution. Going back then to Holmes and Lord Justice Stuart Smith's decision, when analysing the cases, he spoke, to my mind, this indicates that the Bonington principle had been and was directed to a case where the tortious exposure contributed to the onset of the disease and not its severity. Now, that sentence is, in my opinion, I'd be interested to hear what other people think, difficult to square with what he said at paragraph 31. And that begs the question, are we looking at material contribution to an injury, or are we looking at material contribution to an event? I think that's a very interesting question, and one which the courts are going to have to grapple with. If you look at material contribution to an outcome, that's a very clinical negligence analysis. But a material contribution to an event seems to me much more of an industrial disease analysis, because it is easier to compartmentalise the tortious exposure that you would commonly associate with industrial disease. Does anyone have an opinion on that? I'd be interested. Yeah, please go ahead.
Just the former, I think, is much easier in terms of causation, because if...
To outcome, you mean?
No, if we just choose the industrial disease...
Yes.
Because, as Frank was saying, if there's sleep, it's much easier to prove from medical records if a patient or claimant or whoever has sleep deprivation or sleep issues within 3-6 months of the accident. They get amitriptyline, they're also prescribed amitriptyline, they're going in, I can't sleep, the pain's waking me up.
Yes.
So then you don't have to prove that it can contribute to the severity of the disease. To me, that's a much easier argument to make.
Well, I'm inclined to agree with you.
Just on that point, I was going to ask Frank, obviously, he wanted to move on, but I just wonder if maybe looking at this a little bit, looking at it a little bit differently, because I agree, so many patients develop fibromyalgia without trauma, right, 2/3.
Yes.
But maybe to look at it in a way that patient had an accident, a car accident, whatever the case may be. But then it's not that the accident directly caused the fibromyalgia, it's that the accident caused the sleep that caused the fibromyalgia. So it's not really the trauma, it's just the trauma set up the situation, set up, put the wheels in motion to cause the fibromyalgia. So it sort of almost takes the accident out of it, because we need a set of circumstances. A set of circumstances, Frank's view, is that it's sleep, right? And then that sort of cascades and snowballs into fibromyalgia. So it could be just the accident. It's not directly. It's enough to get us all causation, because it sets in motion the chain of events that leads to it. But just when Frank was speaking, it just occurred to me. I've been doing this for a long time. I never thought about it that way.
No, it's an interesting point, and I think it really is going to come down to this notion of event and outcome, and I think because it's such a difficult area of law and there's so many cases, and it was always very much an industrial disease area of litigation, and material contributions rapidly catching up in relation to, clinical negligence and material contribution are rapidly catching up. I think that is, in your analysis and your analogy, if you were to approach that on a conventional, but for, you're not going to win that argument. But if you're talking about, setting the wheels in motion, that could only be a material contribution. But then the question is it divisible or indivisible? Because the claimant will want it to be indivisible, and seek to recover 100% of the damages. Whereas it's divisible, there'll be an apportionment that's being made. I mean, I think it's very, very difficult, but if you closely read the clinical negligence cases, the recurring theme is end product outcome. Yeah. Bailey, Williams, they're talking about CNZ, they're talking about this claimant patient has found themselves in a total state, hypoxic brain damage, and there has been a deterioration into that, either through a couple of minutes or potentially a longer period of time. It's an interesting point that you raise.
Carry on, but I can talk about it for hours.
Yeah, we'll discuss it later.
Yeah.
Okay, so if we're going to take forward an analysis of material contribution and indivisible injuries, you'll have to overcome generic and individual causation. And again, this is something that has always been quite widely used in America, this sort of two-stage test. And it makes sense in the decision in Holmes, why the Court of Appeal analysed it and put it forward as this. Because the agent TCE, there was a very live question about whether in fact it could cause Parkinson's disease. And you'll see my third bullet point is whether or not it is in fact reflective of an industrial disease case. And in Holmes, the conclusion was that exposure to TCE only constitutes a potential risk of Parkinson's. They weren't willing to go any further, even with epidemiological evidence on that. Now, again, that works quite neatly in industrial disease cases, but it may not be so neat in clinical negligence cases, because whatever case you find yourself analysing and working on, you may not, and your expert may not be able to pull out a paper that immediately says, oh yes, this is clinical experience more often than not. Now, obviously, there's lots of papers taking hypoxic brain injury that we know that a lack of oxygen, and usually I think it's widely accepted that if a fetus has been starved of oxygen for 10 minutes or more, there will be a degree of brain damage. But obviously, in other areas, taking Bailey as an example, this is simply aspirating on vomit. You're not going to be able to necessarily pull a perfect academic paper out that says, oh yes, if you aspirate on your vomit, you could end up with a brain injury. So I flag it as an interesting point. But again, sorry to keep coming back to it, it links to how are you going to analyse this as events or outcomes. Interesting. And then individual will, of course, be to the specifics of the case. Now, this is an area which, if anyone's ever spoken to Charles Feeney, he's got a real bee in his bonnet about this. What constitutes material? The courts always say, well, it's more than de minimis. And I come back here to the decision in Wiltshire and Essex, which you should all be familiar with. And that was where the baby went blind, and there was 5 possible causes, only one of which was negligent. On the evidence as the case was heard at trial, there was no or insufficient evidence to show that the breach of duty, which was administering too much oxygen, had in fact made a material contribution. So they were effectively left with these 5 theoretical possibilities, any one of which could have caused the blindness, but only one was associated with negligence. So that's a very important decision when you're going to analyse causation in fibromyalgia, because we've all heard Frank say, well, this is an individual that had a series of predisposing factors, and absent negligence, there is at least a theoretical possibility that this individual could tip into developing fibromyalgia. If you've not read the decision in CNZ, I do recommend it. It's quite lengthy, but it's worth it, because of Mr. Justice Ritchie's secondary ruling as to causation. So in that case, he found that on the conventional but-for analysis, but he also gave a secondary ruling on causation, and that he considered that the claimant was entitled to 100% of the damages in terms of functional outcome, even though the claimant would have been brain damaged in any event on the premise of the secondary ruling. And that's in relation to the duration of the hypoxic ischemia. And that's very interesting because he's again saying, look, this is an individual that even on my secondary ruling would have been brain damaged, but on a material contribution analysis, I'm going to award 100% of damages. It opens up, which is for a separate discussion, whether or not the courts do need to revisit the question of apportionment in cases of material contribution on an indivisible basis. You'll all be aware that in the decision, I think of 2006, but early 2000s really, of Barker, where the court said that they could do that, but they would promptly Parliament intervened with Section 1 of the Compensation Act. So bringing this back to an analysis and interpretation of fibromyalgia, we have an individual who, by virtue of the disease, has a predisposition towards it. There's multiple different agents that could potentially lead the individual into developing fibromyalgia, but then a tortious agent comes along as well. So that then puts into sharp focus the importance, if you're proceeding upon an indivisible analysis, of the decision in Wiltshire and your evidence to say that it did in fact make a material contribution. What's material? More than de minimis. Okay. So, are we able to draw any conclusions, admittedly, from this very short talk? I do think that there's going to be a bit of a shift in the case law and interpretation as to whether or not what constitutes indivisible. I do think that there is, reading the cases, that there is a difference in approach between disease cases and clinical negligence cases. That's just my interpretation, but I think the decision in Holmes is good evidence of that. As I say in the second bullet point, is the assessment of indivisible based upon the final outcome? Certainly it was in Bailey and CNZ. Or is it the process of exposure? Question mark Holmes, although it could be argued that there is at least some ambiguity in the approach taken by Lord Justice Stuart Smith. And as I say, should we talk about an indivisible injury or should we talk about an indivisible event? Putting my opinion forward, I think that fibromyalgia should be considered an indivisible injury. As a condition, it is binary. You either have fibromyalgia or you don't. But there is difficulty because, as you heard Frank say, there is a degree of fluctuation about someone's symptoms, but that's a fluctuation of symptoms. I think fibromyalgia is more akin to CNZ and a hypoxic brain injury, the progressive development of the condition, and then once it's triggered, you have it. But we know that a fetus that had been deprived of oxygen for 12 minutes may not be as disabled as a fetus that had been deprived of oxygen for 18 minutes, say. Anyone want to disagree with me? By all means. Okay. But in terms of practical guidance, I would say always have in mind the actual facts of the case. And from a claimant's perspective, you need to think, well, how are we going to get over Wiltshire and Essex? From a defendant's perspective, you will be looking and analysing to say, well, does the evidence actually show a contribution, or is it simply a case that this individual had multiple known risk factors and developed fibromyalgia? So would have developed fibromyalgia in any event. Not a difficult, is a difficult, not an easy question to answer, and you will, as Frank says, you will have to be very alive to the case history and the progression throughout the clinical records, because the symptoms will have probably been going on for years and years and years, and it may be that the individual already had fibromyalgia, just didn't have a diagnosis. An incident happens, a car accident, and they become aware. But as Frank said, if you actually go back and look through, you can tick off the relevant criteria for a diagnosis. Okay, sorry, we're a little bit behind time, so we'll try and speed up. We were going to present two case studies to you. One was a road traffic accident, and a clinical negligence one as well. I think just because of time, we'll probably just do the one. So a very quick show of hands. Who here is a clinical negligence lawyer? Right, so let's do the clinical negligence one. Right. So, Frank, do you want to come back up?
Yes, so, I mean, these were a couple of cases that I had recently that Charles asked me to dig out. So, a 50-year-old man, builder, lived with his partner, 3 teenage daughters, said he had a number of musculoskeletal injuries in the past and a major history of alcohol abuse, sleep apnea and depression. So going through his records, going back to 2002, you can see entries of shoulder pain 2002, multiple joint pain 2013, aches all over 2014, stress, anxiety, struggling to sleep, anxiety and low mood, facial pain and so on. And then July 2020, major anxiety, not sleeping well, didn't leave the bedroom, never mind the house. So quite major psychological issue. Do you want to do the next one? He was prescribed sertraline. He was also given gabapentin. Now his GP advised him that that there was a risk of hyponatremia, low sodium level with this combination. Anyway, he was drinking very heavily, went to alcohol detox. Within 3 days of the alcohol detox, stopping alcohol, he had a convulsion, which was almost certainly because of alcohol withdrawal. But he then went into an A&E department and waited for quite a long time and had a further convulsion, a respiratory arrest and a cardiac arrest. And he was then treated with CPR. And then shortly afterwards, he was diagnosed with fibromyalgia. There was an incident where the hospital admitted liability in relation to what happened in A&E, but then there was a question of whether the liability and the negligence was the cause of his fibromyalgia, whether it made it worse or whatever. So that's
Okay.
that's the history.
So, approaching this, the issue is, of course, when did he have fibromyalgia? So we have all of the risk. Well, we've certainly got risk factors going back many years. 2008, there's an entry of tired, anxious, muscle ache. He's got sleep apnea and he's got depression. So I think everyone in the room will agree that he's got the principal risk factors for fibromyalgia. Now, obviously, there's no clear documentation in the notes that he had it before. So, Frank, in your opinion, is there a reasonable argument to say that before the cardiac arrest, he was suffering from fibromyalgia?
Well, he denied it. The records suggested that he did. Mm-hmm. If you want to know what I concluded when I reviewed his records, I thought that he had mild fibromyalgia before it was locked up with his alcoholism and so on. His fibromyalgia was established sometime before this. That was my view, and I can't remember who I was whether I was instructed by, but it didn't make any difference. Yeah. That was my opinion.
If you were asked to consider whether or not the cardiac arrest is an event, do you think that could be sufficient to trigger fibromyalgia?
Well, the psychological trauma that he described afterwards would be sufficient, and the persistent pain disturbing his sleep is what he said. So because he following the CPR, and there are records also which said that he had severe pain. I think there was a broken rib or two, and that he had difficulty sleeping for quite a long time. And then there was a question of whether he had post-traumatic stress disorder and so on after the event. So if it hadn't been for the previous history, then that did look as though it was sufficient trigger to me
Do you
To
think
be-
that
to
in,
be-
do you think in that trigger that the pain, for want of a better description, of undergoing CPR and the psychological trauma, do you think that they're working synergistically together? Effectively, you're getting a double dose.
I think that and this it's quite difficult to often separate out. I actually think that painful conditions in the absence of psychological factors are probably not going to be sufficient. I think that unless there are major psychological vulnerability, and then you've got something painful which is stopping you sleeping. But I think that when you've got something that is painful that may be stopping you sleeping, and you've got added psychological factors, then the two work in tandem, I think.
So do you think, would you agree with me that this is an instance where there's obviously a non-negligent agent in play, but then the negligent agent makes at least some contribution to the outcome, i.e. to fibromyalgia?
So the only negligent outcome is had he been monitored correctly, wouldn't have had the cardiac arrest. So that was the negligence.
Yes. So he would have avoided a cardiac arrest, and he would have avoided CPR and.
He would have avoided that.
Yeah.
So the cardiac arrest only occurred because of negligence, is what the hospital accepted. Was that the question? Sorry.
Effectively, yes.
Yeah.
Okay. Show of hands. Just because I'm conscious of time. Right. Who is willing to go out on a limb and agree with me that it's an indivisible concept? There's no right or wrong answer here. Who thinks it's divisible? Who needs more time to think about it? Okay.
Can I just ask a
Yeah.
question? In the records, it said that his mother had fibromyalgia. Mum had fibromyalgia in December 2014. Is there a genetic predisposition?
There's a familial one,
Yeah.
but that might be because of societal reasons, that deprivation and so on were related to.
So it's not like
Various
because your mum
factors.
had it, you're
It's
gonna
not.
get definitely, yeah.
It's not like Huntington's disease.
No.
Okay. All right. Well, does anyone have any questions or comments about this? Okay. Yeah. Frank, yeah.
Can I ask a question? So I've never really quite understood. So I think this is an exacerbation, and I've never quite understood why where the law sits on that. So if somebody has an exacerbation of a condition, then does that just mean you look at the losses
Well,
related to that?
Yeah, it's very difficult because, for example, psychological injuries are classically indivisible injuries because it's in the totality of your mind. But an individual may already have had a long history of psychological illness, but then something happens and they now have a diagnosis of PTSD. It's it's like death. You are either dead or you're not dead. And the way, as I said, apportionment is going to become a very big question. It's always been a big question, but in a case of an exacerbation, you would look to say, well, what is it that the individual could have done before, and what are they unable to do now? Or phrasing it the other way around, what is it that they were restricted in before? So if you were sitting at a 5 out of 10 and you exacerbate someone to a 7 out of 10, you are only obliged to compensate for the increase. That increase could, of course, be very significant. But in terms of divisible and indivisible, you're looking at the onset. So asbestosis, I'm sorry I keep coming back to disease because that's where so many of these cases were, but asbestosis is the classic indivisible injury because you contract asbestosis, and then the more asbestos particles that you're exposed to, the worse your condition, compared to mesothelioma, that when you get it, you've got it. And you won't be able to tell which asbestos fibre had the effect of triggering the mesothelioma. Likewise, in Bailey and MOD, there was a progression, a deterioration to the aspiration of vomit, which was both tortious, contributed by a tortious and non-tortious factor, but the vomit and then the asphyxiation and brain damage was determined to be indivisible and outcome orientated. Now, obviously, Lord Justice Waller in Bailey didn't use the word indivisible, but it was widely sort of accepted that when the House of Lords gave their decision in Bonington, and whilst they spoke about divisibility, they in fact probably meant indivisible, as per McGee and everything. But so to answer your question, it's difficult. And if there has been a legitimate exacerbation, the defendant as the tortfeasor will only compensate for how they've made the condition worse. But in this instance, if the defendant successfully argued either that he already had fibromyalgia, which is akin to your opinion on it, or that he always would have developed fibromyalgia, it becomes a much lower value claim, because it's then similar to a psychiatric illness case where whilst the psychiatric diagnosis is indivisible, you can break down what they were previously able to do or not do, as the case may be. Does anyone else have any questions, comments, either about the law or fibromyalgia? Okay, well, that's...
I think
Yeah,
it'd be
sorry.
interesting to have statistics of fibromyalgia symptoms intra-litigation and then post-litigation.
I think that would be interesting, yes.
Because that in itself is such a stressful experience, and whether that has any
Yeah, absolutely.
impact on their symptoms.
Well, probably. There's always been a great sort of sympathy and acceptance on both sides of the profession that litigation is stressful. But you often see it cropping up in psychiatric cases where they say, I'm really struggling because of the litigation. I mean, Frank, what do you think about that?
Unquestionably, the stress. Well, we know that general stress levels are a contributory factor to the development and the persistence of symptoms, and therefore litigation hanging over you very much is the case. And from a clinical point of view, I've even when I've been involved with that, encouraged patients to try and resolve the issues as quickly as possible for their own health. And I think that's true. But how you quantify that, I think, is a more difficult matter.
And I guess causation as well, it raises that question too, doesn't it? Is it the accident or negligence, or is it the process of the litigation after that triggers the fibromyalgia, the stress of it subsequently?
Yeah, that's a very fair point that I could certainly see coming up in certain cases. We've all had cases where the claimant starts out at this level, and then midway through the litigation, he or she takes a real downturn, either physically or psychologically. It'll be an interesting argument to run in front of a judge that the whole process of litigation is turn this from a Y case to X case. So yeah, interesting point. Okay, anyone else? I mean, I'm not closing it down. I just think because of time and those that do need to get off, please do so. But if anyone wanted to have a quick drink afterwards, please do feel free. We're just going to go across the road, but I understand if you need to shoot off, that's also quite okay. I won't be offended. Okay, all right. Thank you then, everybody.